And our next speaker is Vishal Diwan, who is an Associate Professor of Public Health and Environment in Guardian Medical College. Vishal's got a Master in International Health, he's got a PhD, is an Associate Professor, as I said, in Public Health. He also works with the Karolinska Institute in Stockholm. He teaches master students doctoral programs and also is involved in evaluating maternal health services in India and research capacity building as staff and students on social determinants in health. So a very wide portfolio of work, and thank you very much for being with us today.
Thank you very much. Hello everyone. I'm quite happy to be here because I studied my Masters in International Health in UCL in 2006-2007. So I'm coming here back it's quite good to be here. And I'm going to present the result of a tool which we used in our ongoing research project in India that does mobile-based reporting of childbirth event work in low-income setting. Before going to the actual result, I would like to say something about the background that effective reporting of events around childbirth is essential to better planning and service delivery. However, current reporting systems are weak, especially in rural areas. Mobile phone usage is rapidly increasing in rural India, and therefore we evaluated the use of mobile phone-based reporting of childbirth in rural area of Madhya Pradesh province in India. The background is we have a EU FP7 project that is evaluating the maternal health project focused on reducing maternal mortality in India. And we all know that in India it's not that maternal mortality is or maternal MMR is even. There are some 9 provinces in India which has around 48% of population, 59% of total birth, and that contributes 62% of maternal death in whole India. So maybe you have heard about this a program which is called Janani Suraksha Yojana. It's a conditional cash transfer scheme because before 2005 the institutional delivery was not much in India. It was around 30% in most of the states. So the government of India thought that okay, if we want to reduce the maternal mortality, we have to increase the institutional delivery, and then they started this conditional cash transfer where if you deliver in public facility, you get the mother gets some incentive, and they assume that it will decrease the maternal mortality. So the overall project, this EU project, is about evaluation of this big maternal health scheme in Madhya Pradesh province, and we have documented the trends in program uptake. We have also studied the cost effectiveness. We have also studied that what type of who is coming to the delivery and what type of mother is coming depending upon their socioeconomic status, and we have also studied the transportation, emergency transportation. So this is our study area is Madhya Pradesh. Madhya Pradesh is a centrally situated state, and it has population of around 72 million. Mostly 2/3 population is rural, and the maternal mortality is also quite high. And we worked in western part of state called Ujjain. The district is Ujjain. So when after 2 years, when we wanted to measure that who is coming to the facility and what type of mother are getting delivery at home, and we also wanted to measure the proportion of complications, and we also wanted to relate those with their household wealth characteristics. So the challenge was how to find or how to get the mother of the number which we got. Like we calculated around that for this whole district, the population of district is 1.9 million. And we wanted to based on our sample size, we wanted to interview around 1,700 mothers who will deliver in next 1 year. And so we have selected around 153 villages. There are around 1,000 villages in this particular district. And we have selected around 153 villages based on their number of deliveries. And the challenge was how to get the information of deliveries within the required time, that is like 24 hours or 48 hours. So then we decided to use mobile phones or mobile technology, that if we get a birth report on time, we can go either to the home or to the facility to take the interview of the mother. So what we did is we decided to use the mobile phone, and then to get all these 1,700 mothers. So the first task was that who will be our key informant. So we identify about 500 key informants. We visited all these 153 villages. We identified 500 key informants. The key informant mainly were the ASHA worker. This is a women community health worker appointed by government department. They are not what you call they are volunteers. So they are not on payroll to the government, but they get the incentive depending on the number of deliveries they bring to the hospital. We also contact the traditional birth attendant and other child development services worker, and key informants were approached and introduced to the project. And what we said them that if there is any delivery in your village, we gave them a number and you would call to our call center, and then they got an incentive of for each delivery they got incentive of around 100 rupees, that is around less than $2. So we have established a call center in our institution, and the call center is not a sophisticated call center. We have 2 people who were they were getting the call all the time. Like if there is any delivery, they get the ASHA worker or other worker, they call our research assistants, and our research assistant write the basic information about from where the call was coming and who was calling and where the mother is delivered, either in the home or the facility. So in this way, we were able to get the required number of our 1,700 mothers. And then we also evaluated the phone calls. Like one thing was to visit the delivered mother either in hospital or home, so that is the one way to validate the call center information. And also because it was a research project, so we also sent our surveillance team, we call it surveillance teams, to verify the call and to find any missing mothers or delivered mothers in the village. So this is the result. This study was, the main study was conducted for 1 year, till we got the required number of mothers or deliveries. And before that, we also did pilot study to test the call center. And then in the pilot, the performance of call center was 68%. So 68% out of 469 deliveries, we got call of 320 deliveries. And then we thought that, okay, our call center is working fine. And then we started our main study, and it was for 11 months. And by the end of the study, after 3 or 4 months, we got the performance of 85% reporting. So we were getting only 15% deliveries were not reported by the call center. So this means that the system has worked, and we got our number. So of all the deliveries in the study villages, 85% were reported through mobile-based system. And the reason of non-reporting gradually reduced was mainly due to ASHA being away from the villages for personal work. When we see the performance of the key informant, we saw that most of the call was received from the ASHA worker. So ASHA worker is already trained in giving sending or taking mother to the hospital. So they were the key informants. 75% reports were received within 24 hours of delivery. And so that is the early reporting, and that's what we want in our research. And then the good feasibility was there because we didn't have any operational difficulty. Network connection was good. And we also, we thought that, okay, women will not able to give the information, but 90% or 95% of our informant were women, and we got a good reply. So in conclusion, what we can say that mobile-based reporting of childbirth is feasible in low-income setting and has potential for upscaling. Thank you very much.